of it is really the future of micro neurosurgery itself, because this is one of those areas which, if ignored, we're going to deny patients a good treatment for many diseases. And this would be missed for the patient and for us neurosurgeons to give the patients this opportunity. And this comes from the fact that the way to be able to provide this option for patients in the future is only going to be by mastering the anatomy of this region, and at the same time believing that microneurosurgery could be of help. The trend that has been going on for a while now, assuming that microneurosurgery is becoming extinct or it's not going to be useful in the future, I think it's a big mistake towards the neurosurgeons, but number one, towards the patients. And those who are doing it, we are living the benefits of it every day. So this is not going to go away. The truth of the facts are not going to be going away. So that I would advise everyone, especially the young neurosurgeons, to invest time in learning it. And unlike what everybody says, that it's going to be very difficult or a steep learning curve, that's not true. It's all in the lab, it's all available, and we've had masters and mentors which have led the way before, like Dr. De Oliveira in this region, and we should, based on their advice, take what they have done and do more with it, and then the younger people will even do more with it. So the title of my talk is Cavernous Sinus is a Path and Destination, because there are two benefits from knowing how to operate in and around the cavernous sinus. One is you'll be able to tackle lesions in the cavernous sinus, and number two, that you will be able to treat lesions through the cavernous sinus, because it will allow you to get great exposures to lesions which has been deemed or considered impossible to deal with or very risky to deal with, and you cannot get close to them, or it's almost forbidden to get close to them. A good example is the basilar aneurysms, and we will soon be publishing our series. We've had 183 cases now, and we will elaborate on this aspect of it. But it's also useful for not only aneurysms, a lot of other vascular and tumor surgeries that can be approached through this region, which makes it very accessible. So this is our institute that Marcio alluded to, and again, we are very welcoming to anybody who wants to visit with us. It is connected to our hospital, and it's also a rehab in the background there. This has three main components to it. It's the Yazergil Microneurosurgery Research and Education Center, as you can see, but also it has the auditorium, which is connected. These are our fellows, and they're actually attending the lecture as we speak. And the Brazilian Society, led by Dr. Borba, has done a meeting here. And we have meetings every 2 months, and one of the meetings is Dr. Almefti's meeting, and this is done in his laboratory, which is can take up to 40, 50 people there. He's one of our fellows, and it also we nowadays we do all our courses with life surgery, and there's also a conference room named after Dr. De Oliveira, Professor De Oliveira, who has been a main supporter for our program here. So, like Marcio said, we are we welcome anybody who wants to come and spend time. Just contact us or contact Dr. Aboud, our lab director. So coming to the cavernous sinus, um, the I like to put this title, which I will change later. There is also the complexity and simplicity of the cavernous sinus. And what that means is, some of us look at it as a relatively simple area to navigate. Some look at it as a complex area to navigate. And what makes the difference is one point which I will allude in a few minutes. Now, there has been failures in the past in dealing with the cavernous sinus, and that led to conclusions which were wrong. Instead of revisiting, navigating, looking at the people who has continued to do it, Dr. Al-Mefti, for example, has been on so many podiums screaming all the time because he has the clarity of seeing what he can do in the cavernous sinus and around it. And we should take the times we failed to include them as part of our success plan in a way, because as mentioned here, it's not the opposite of success, but it's part of success. What happened in the past is many who has ventured into the cavernous sinus were not really ready, and they had problems, they had complications, and they didn't know how to handle many of the pathologies, and they felt like the cavernous sinus is too complex and too risky. Well, if you think about it, anything we do is complex and risky. Removing an insular glioma is complex and risky if you're not equipped to do it. Removing a convexity meningioma could be complex and risky. You can injure a bridging vein and end up with a major hemiplegia in a patient and seizure disorders. So in the cavernous sinus, it has been decided because many did not want to really invest the time to learn it, and the reaction was it's complex, it is not worth it. It's easy to say it on your behalf, but that makes it a popular thing that we shouldn't be touching the cavernous sinus. And that's a pressure which a lot of people, are forced to accept. There are even, as we all know, programs that never seen the cavernous sinus. The resident never been experienced to see it. And in these cases, you end up conforming to what's popular in a way. But the problem is the patient are the ones who are going to suffer, because there will be cases where there is no better options, and the options that were used are not the best options, or they fail in a good number of patients. So we cannot just be afraid or learn how to be scared from something without going to the people who are not scared from it and find out how they're managing it. It's like, some people are dealing with lions and they know how to tame a lion, and they know how to deal with it on a daily basis. And for that reason, it's pity that we're missing a lot of young people who, if they were thinking and participating in the process of treating the lesions of the cavernous sinus or through the cavernous sinus, we could have had much more progress by now. But it's been isolated to small islands around the world where few people feel comfortable with it or believe in it, and that's where it's happening. But fortunately for us, we have the clarity because we see the benefits in our patients and we cannot deny it. So we need to have this excitement and wonder and keep this sense of wanting to learn it. And it is a fascinating area. It's a beautiful area to operate in and to learn. It's beautiful anatomy, and at the same time, it's beautiful results because you're really operating behind the eye, under under the brain. So these patients, you'll spend hours taking the tumor out and cleaning it, and they wake up immediately and they're gone home within 2 nights in the hospital, because it takes the surgery away from the brain cavity to the skull base under the brain and behind the eye. So I advise that we don't have a passive mind, which is you consume the information and you start just repeating it the way it has been talked in or taught in a familiar form. So we need more creativity. We need the neurosurgeons to start thinking in a different way, to have an active mind, which you transform everything you digest into something new and original. So you create instead of consume. Because with all my respect to a lot of the meetings we go to, and you hear it from each other, everybody goes to a meeting, they say, well, I didn't learn anything. I didn't have anything new to use. Why? Because we have this passive approach and we are just regurgitating what's familiar instead of tackling the challenges that we have. If we're going to accept a standard of care, then we're going to pile up patients who have lost opportunities in their treatments early on. And then later on, by the time we end up seeing them, it's a catastrophe, because then it is a benign tumor becomes a malignant situation. Even like aneurysms, some aneurysms start as benign clippable aneurysms. By the time they get referred to me, it's a malignant aneurysm. Because what's the definition of malignancy? It's somebody that can kill you and it's harming you and cannot be treated. And I have many of them, unfortunately. So again, it's always important to know where your knowledge coming from. It's not something that I'm saying which I have created. It's always good to have a creative mind, but I give credit to my teachers. I have learned a lot from, number one, Dr. El Mefti and Dr. De Oliveira and Dr. Dolink. I had the golden chance also through their acquaintances to get to know him. And we're all under the umbrella of Professor Yazergil that cannot be forgotten because of his push for microneurosurgery. And he is I've visited with him recently. He's in good health, and I hope he stays like this. And I advise anyone to visit him in Turkey. You will enjoy every minute of it. So you have to approach the cavernous sinus. You have to maintain the thinking of visionaries, which is nothing is impossible. And if you don't think in this way, then we're going to play the statistics game and say, well, we have treated 80% of the patients successfully, 20% didn't work. But what happens to those 20%? And that 20% is 100% for their family. And this is where those failures become an intractable problem that you cannot treat. Or when the time you get to treat them, it is an impossible situation. So we need to overcome this fear and approach it in a different way. And one of the main approaches to it is to understand how these tumors grow. The pathology of any of these tumors is not haphazard, and it is well-defined behavior. Nature is not crazy. It's not even malignant gliomas that used to be thought infiltrating everywhere. After working with Dr. Yazergil, it became clear that they have a pattern of growth. So nature is not crazy. It has a predictable pattern. And the same with tumors involving the cavernous sinus. Each tumor has a different behavior. The way they distort the anatomy is different based on where they start. A tumor that starts from the pituitary gland pushes everything laterally in the majority of cases, and then it starts going around structures. Tumors which are coming from the posterior petroclival junction, they push things anteriorly, and so on. Chordomas which grow more lateral are different than chordomas that go more medial. So that understanding how tumors and where they come from and how they distort anatomy is essential. And in meningiomas, an example, and I'll focus in the talk here on basilar aneurysm, which is the approach as you go through the cavernous sinus, and when meningiomas arising from the cavernous sinus. The others are less involved in a way. Operating on pituitary adenomas is something that's very, very kind of, I have to say, it's really easy nowadays. And we have many patients who've been cured with invasive adenomas, with growth hormone secreting tumors. And I'll be happy to share a lot of experiences that we have by now. But these tumors, with what I observed is they really arise from this corner, which is the point which is under the third and fourth complex, and in the region where the Dorello's canal superior aspect of it. And this is why a lot of these tumors present initially with a sixth nerve palsy. And then they grow in different ways. And it depends on how they grow is the way the tumor spreads. But they are the same origin. And then they can grow. In one tumor, you see more growth in this direction, and another tumor more growth in this direction, another tumor more growth in this direction. But they have, the roof of this corner is the tentorium, and the floor of it is that corner of the cavernous sinus, which is next to the posterior genu of the intercavernous portion of the carotid, where the ascending and horizontal portion start. Now, how do we prove that? It's observation. You look at the small tumor, the larger, and so on, and you see how they grow, and I'll show some pictures of them. So to be able to get to operate on this region, it's clear you have to do your homework. That's important. And, achievements are not chance occurrence. You have to put the effort, you have to go to the lab, and it's an enjoyable time. And at the same time, this is how we improve our knowledge. And the lab is something that is indispensable. We cannot live without the lab. We will stagnate. Our surgery will be boring, as well as also not good, because you're going to repeat the same mistake if you don't go to the lab. When you do something and it's difficult, it's not because it's difficult. It's because there's some knowledge that's missing. And if we go to the lab, the minute we realize we had a difficulty in a case, then we will make it easier the next time. And that's how we can progress. But to do that, it's a lifetime job in a way, and we have to do it continuously. So, long hours and tremendous effort. This is the properties of every neurosurgeon. When we hire someone, it's the first thing we look at is how long hours they can stand, what's their stamina, and so forth. And I think 95% of the residents we choose have what it takes. But unfortunately, there is a lot of changes that occurred in our specialty to where there's a lot of trending towards how can you work less and get more rest and maybe make more money and so forth. And that has to change, because what's happening is we're producing a lot of people who are bored, burned out, and not contributing. And a lot of them are very smart. And we need those smarts to keep them. So we need to invest and put your heart in it in order to achieve it. There's like this beautiful piece of work. It's long hours. This is Michelangelo's Sistine Chapel. It is long hours and dedication. And he said it himself. He said, if you see how hard I work, you will not be impressed by my product. He doesn't think so. Imagine. So keep the determination, because, during this path, you will be faced also by a lot of people who will tell you, don't work on the cavernous sinus. It's not worth it. I'm telling you, it's worth it. I deal with it, and it's It's a road that will get you places and it will save you from trouble a lot of times. So to do that, it goes back to the basics, mastering the basics. What are the basics? Anatomy. It will always be the number one basics that we will go to. And what anatomy means is not only to know that what nerves go into this point, you will know if you look up what's there, if you look right what's there, and if you look back what's there, and in front of you what it is. If we take you and put you another point, you should be able to get this mastery of the anatomy in order to really be safe in the cavernous sinus. You have to know the distances, how they're distorted, and then to know the pathologic anatomy, where these tumors come from and how they distort the different structures. And again, this is not something impossible. It's something that just needs effort. And as time goes on and we transmit the information, it's going to be easier and easier for the next generation. The problem that we have now, and I'll allude now to the meningiomas, is this is the problem. This is for example, a paper which was accepted and published, and the two pictures are a problem. This is its evolution in treatment of cavernous sinus meningiomas. This is not a cavernous sinus meningioma on the left side. The one on the right side is the wrong cavernous sinus meningioma. So you can tell from the get-go that there is a problem with the way things are defined. Meningiomas are not in this shape usually. These nerves are usually on the surface in these tumors. And this is a medial sphenoid wing meningioma or a spheno-orbital region meningioma. But it is not usually it cannot be considered a cavernous sinus meningioma. Now, I have a problem with this because not only are those pictures wrong, but this is a published paper. So whoever reviewed it also assumed that this is correct. So that tells you that the knowledge, the depth of the knowledge for the cavernous sinus is really missing, and that has to be remedied in a way. So let's look at what we end up doing, and I'm sure you've seen Dr. Al-Mefti's lectures and you've seen him show these catastrophes. This is a patient who started with a small tumor. By the time I have seen this patient, she has lost vision, she has big tumor, and she also has complete cranial neuropathy on that side. She had every form of radiation known to man given, and she's had 3 operations which predominantly just came close to the cavernous sinus and left the tumor. And you can see the surgeries are here, and what's missing is the temporal lobe in this area, but there is a lot of tumors still in there. And in this case, these are easy tumors now to deal with, except their pathology is more difficult because they tend to recur because now they have changed in their behavior. But if you look at the surgery itself, this patient had already lost all the cranial nerves, and the resection will be easier. We were able to clean it well, but unfortunately, the morbidity is already established in this case. And this is not where we need to be. And again, it's easy to say 15-20% of patients don't do well, but 75-80% with whatever treatment you do are doing well. Well, 15 to 20% is not a small number. And again, if it's your family member, it's 100%. So we have to be prepared to do better. So again, this is another example of a case which this patient was told to go home and die, and nothing can be done. And you can see the compression of the brainstem. However, this patient had so much radiation, everything, proton beam, gamma knife, any knife you want. And then the artery was already almost closed here. She passed the balloon test occlusion. The surgery is easy. This is the clip artifact, and this patient is still alive, big tumor removed. But again, the morbidity is already established in this case. So doing incomplete jobs is not really what we have to aspire to. And we have to master how to do it the right way. So, and like Michelangelo puts it very nicely, it's a greater danger if most of us lies not in setting our aim too high and falling short, but setting our aim too low and achieving our goal in a way. And as in our specialty, we have to regain this approach. We have to go back and start putting the bar much higher and work hard in order to get to that level. It is wrong to just accept that a certain number and play the statistics game. Statistics are patients, they're not numbers. We have to keep that in mind. So we have failures, but these are opportunities, and then we can work and get a perfect result. And that's what we need to do. And I have no doubt when it comes to the cavernous sinus that we will achieve pretty soon, not too far from now, a grade 1 Simpson resection once we're able to replace the carotid artery, which we should. So what's happening now, when we have failure, there are a lot of people who eloquently present it like it's an acceptable thing. I call it the eloquence of failure. This is an example for gliomas. Plasticity leads to better resection the second time around. How can this be accepted? If you couldn't take it the first time and you came back again and took it and everything went well, you assumed it's plasticity. It's like I didn't do bad the first time. It's okay to say I couldn't remove it the first time, I wasn't comfortable. Then I reassessed it and I was able to go back and remove it. But to create science which is fictitious to justify failure is wrong. So I'm giving this as a warning because there is a lot of eloquence about wrong things. And the eloquence may be impressive in its presentation and it looks correct, but it's incorrect. And we have to be careful about it. So when it comes to the cavernous sinus, I'm going to change what I said. I said complexity and simplicity. It's actually the ignorance is what leads to complexity, and the knowledge is what leads to simplicity. So this can be achieved by looking with our brain eye. When you have the right knowledge, then you're able to see things differently. I use this from Professor Yazegel, who used to talk a lot about the brain eye, to where you're not seeing only with your eye, but you have the insight to see the pathology and the problem. Michelangelo presented it beautifully, saying, I saw the angel in the marble and carved until I set him free. And this is one way to think about it. This is like the cavernous sinus, is you can say, I saw the nerves in the cavernous sinus and I carved until I set them free. That's how we should approach this surgery. That's how it's approached. So you need the knowledge for it, because I am not an astronomer. When I look at the sky, I don't see much. But when it comes to the cavernous sinus, I can see just like the astronomer can see the stars and he can make sense out of them. But then how do you do it? You find clues. And with the anatomy, one clue leads you to another and so on until you're able to put the picture together again. So coming to where these tumors start, this is what we have, I think an observation which when you see it happening in life and then when you apply it surgically, then it's enough proof to feel like this is the correct way they grow. And if you can see this tumor is in this corner behind the carotid, where the cavernous carotid is, and then the ascending carotid comes up. This is the sixth nerve coming under V1, going down to the Dorelus canal, and that's the fourth nerve. So it's really on the undersurface of the tentorium, and then in that corner at the inner aspect of the petroclival junction. And then when it grows, then it grows further anteriorly, which is where it goes between the carotid in the cavernous sinus and the clinodal carotid. That's how it goes into the sella. And then laterally, it goes into the Meckel's cave region, and it fills it. And then further on, it starts growing around the carotid. And if you notice, a lot of these tumors do not exist much in this corner. Eventually, if they grow enough, they will go into this area. But you can always find V1, V2, V3 on the surface of the tumor and dissect them, and then open the different corners. Then when they grow further, they go through the petroclival dura. And it's interesting, when you're operating on them, you can see the dura preserved and the tumor grows on both sides of it. And then further, it starts compressing the brainstem. And I cannot call these petroclival meningiomas because they're really not starting in the petroclival region. This is starting between the tentorium and the cavernous sinus. And then you can see them growing further through the tentorium into the middle fossa. And you can see this pattern repeatedly. So when we look at cases, this is on the left side, you can see the anatomy, and then let's correlate it with different cases. For example, a small tumor, which is starting as it's shown on the left side, will be this tumor, which is a small area, and this is where it's filling. How do I know? Well, we've had a case like this, we operated on it, and this is exactly where the tumor was, and when we removed it, this patient's sixth nerve improved. Then we have a little larger tumor, which is the same thing. It caused thickening and further widening of this area. And you can see on the right side, the tumor filled this corner going along the tentorium. See, it's following the tentorium along the fourth nerve, and then pushing a little bit under the carotid, under the clinodal carotid towards the sella. And then notice the straight line always on this area. And even if it bulges, it's kind of more smooth. Why? Because the V1, V2, V3 are on the surface, and they're pushed by the surface of the tumor in a way. When it gets bigger, the same, it starts filling the Meckel's cave region, bulging out, and you can see the same growth pattern, and it starts going through the dura of the petrous bone medially, and this is the pattern you start seeing here. And then further growth, you can see it starts going along the tentorium posteriorly, then it starts draping down into the posterior part and lateral part of the posterior fossa, where it starts going towards the 7 and 8 complex in this region. And again, this is how it goes around the brainstem in this area. And then further, when it's bulky like this, you can see it filling all this space, becomes like big room. And the larger one, like the one we showed earlier, it starts going into the middle fossa as well. So the pattern is in front of us. If we watch it, we can see it. And then when we operate on it, we also verify. So how to operate in this region? This is an example of a case, and I'll show the first part. And the surgery is done mostly concentrating on the cranial nerves, because the tumor is living in between the cranial nerves. But this surgery is very much like doing peripheral nerve surgery. You have to find the normal nerve from one end and the normal nerve on the other end. The third nerve at the level of the clinoid is very constant in these lesions. And then if you remove the clinoid, and you will verify the distal runoff of the third nerve. Fourth nerve is next to it the same way. Next to the brainstem, the third nerve is more predictable and can be seen. Next to the perimesencephalic cistern, the fourth nerve can be seen. The fifth nerve, V1, V2, V3, along the foramina can also be. If you drill and widen the foramen, you'll find the nerves, and rarely the tumor will follow them into that region. It can, but usually for cavernous sinus tumors like this, they are contained in a way. And then the proximal part next to the brainstem can be verified. So you have all these tumors I mean, all these nerves verified from one end to the other. You just have to bridge it. The rest of it is dissection, and then you map the carotid during this process. And the surgery is no more removal of tumor. The surgery is really dissection of the normal nerves. And then all of a sudden the tumor is gone. And how I noticed one thing is I used to spend much more time removing a bigger tumor. In the last 2-3 years, they take about the same time, a little more time for the bigger tumor. Why? Because the process of resection is the same. It is dissecting nerves. Whether it's big tumor or small tumor, you just cut a smaller piece or a bigger piece. So this is a correlation between the anatomy of dissecting the cavernous sinus and the pathology in a way. So this is in the lab, and then you go back to the operating room. I am coagulating and cutting the middle meningeal artery. The middle meningeal artery has to be cut because it will free you and untether the region of the posterior part of the cavernous sinus. And then we will dissect and find all this area, and I will show more later. But you can see here V3, V2, V1, and the tumor is in the cavern. This is in Meckel's cave. It is in the cavernous sinus. Fourth nerve is here. Third nerve is here. So the anatomy is verified in almost all the cases. And this is the approach you should be able to get in these cases. So it's beautiful anatomy. It is just pure understanding of it and how the pathology behaves. It's what makes it safe and easy to navigate. This is removal of the clinoid process, and you can see V1, and that's where third nerve is verified. It's always in that corner. And then the first nerve I like to dissect is the fourth nerve, because you find it distally, and it's always the one that is a little buried in part of the tumor, like flowing over it, but it is really still on the surface. And we follow it back until it gets to where it enters the tentorium. If you follow it further, you risk injuring it, and that's the point to stop. The same with the third nerve we'll find. We have V1, V2, and V3 in this region. So then, once you get this out of the way, the fourth nerve, then the next step is to do part of the work which is extradural, and finding V2, V1, and V3, verifying their course, and then you can see the distortion of the tumor, and depending on how much tumor there is in the case, you can decide on it. But then the next is to come to the intradural part, and this is a small tumor. I showed it because it's easier to understand it when you see it the first time. So the third nerve is in this region, which is next to the clinoidal carotid, because this is optic nerve, third nerve coming up here. Now the tumor can distort the nerve here, but this part will be constant, this part will be constant. And I'll show a case later how it is curved and pushed. Fourth nerve is here, you find it, you follow it, you stop. Then you go inside to find it. Now in some tumors, when you open, there will be tumor here. You remove the tumor and you find the nerve. And then you start cutting along the tentorium. And then you cut over Meckel's cave the same way. But the first part, we remove part of the tumor which is in the, sorry, let me. So this is the, again, just to review it, the clinoidal removal, V1, second nerve, and then the next is the fourth nerve. And then we open, once you get to here, we've already cleaned tumor from around it. And then we open the tentorium, which is a subtemporal dura here, cutting it from here to here. And notice the whole surgery is under the brain. you really don't see the brain at all. And that's the fourth nerve course. V1, V2, V3 is here. And then you start cutting all these tumor parts involved in between the different nerves. So it's a dissection of the nerves to get them out of the way in order to get to the tumor. This is the fourth nerve fully dissected. This is the third nerve will be then dissected. This is along the third nerve following it. And I know where the third nerve distally and I can follow the track of it. Then we find this part, you can see the bulge here. And because this tumor, you can see it here going inside Meckel's cave. So now we open Meckel's cave. This is the fifth nerve. And then you remove the tumor from within the Meckel's cave region. That's tumor in Meckel's cave. And this tumor can sometimes be tricky. It will look like it is infiltrating V1, V2, and V3, or the nerves. If you be patient and ease it off, it will come in the majority of cases like little blebs. When it is really invading, usually that's when I suspect it's an atypical or more aggressive meningioma. But you can clean this tumor very well in the overall majority of patients. You can see this tumor has split the nerve, and it entered from this medial wall of it. Then we find the fourth nerve, the sixth nerve, and sixth nerve is a little tricky. And I will show later a picture how we were able to do it. And this is the petroclival junction, and removal of the bone in this region allows the sixth nerve to become easier to dissect. But I will show an anatomic picture later to kind of elaborate on it. This is the tumor in the petroclival dura, which is just anterior to the basilar artery. You can see all this part behind the carotid. This is the carotid. This is the nerve V1. It's all being removed and cleaned. The opening to this area becomes so accessible to where when we finish, this is the view you get. This is sixth nerve. This is Meckel's cave, removed tumor, V1, V2, V3, fifth nerve, and you can see the anatomy well visualized. You can see the arachnoid of Lilliquet's membrane is intact, left all around it. And this is the basilar artery, again, fourth nerve, opposite third nerve. It's a magnificent view of all this region. This is the sixth nerve on the opposite side as well. And this is sixth nerve on the ipsilateral side. And you can really go even lower if need be by going further laterally and removing more of the petrous bone itself to get down to a lower point in a way. So even this is you may say, well, this is a small tumor. This is a big tumor. The exercise is the same. And if you notice how it grows along the cavernous sinus and also along the tentorium. That's why I really think a more relevant name for it is a cavernotentorial meningioma to describe it more anatomically. So this is the middle meningeal artery, and we're going to try this time to correlate the surgery with the anatomy. And if you look at my operations, you'll find out it's almost a duplicate of the same surgery now. This is the meningioorbital artery, which is coagulated and cut. And this is where I start the dissection of the lateral wall of the cavernous sinus. If you cut on the lateral edge of the clinoid, you will not go into the temporal lobe or into of the orbit. And then you find your plane. And obviously, with experience, this becomes a straightforward step. You don't want to underestimate it and look at the video and say, okay, well, I can do it. You need to go to the lab and train, do it, watch somebody who's doing it. Because also, operating in the cavernous sinus is important to understand how to handle the bleeding, the venous bleeding in that region. And it's not impossible. It's not this tsunami of blood. The blood is known from where it comes. You just have to know. This may be beyond the scope of the lecture now, but you need to know where all these are coming from. But this is the exposure on the outside. And then we go to the next step, which is to start removing tumor extradurally. That's the fourth nerve I found here, and third nerve. I mapped the carotid, V1, V2, V3. And then the next step, once you get the extradural part done, then we open the tentorium now, which is the subtemporal dura, because we dissected it all the way back. And you will see now tumor inside the middle fossa, which is going to be here. And this is barely leaning on the temporal lobe. This is the optic nerve here. So this is tumor also on the inside, which we cleaned. That's the carotid. And that's tumor. Now the third nerve is going to be here. And this is imagining tumor. That's Play-Doh that Dr. Abud beautifully put here to simulate the tumor. And now we're cutting over the fourth nerve and skeletonizing it. So in a real life, there will be tumor in these. Now, notice here, for example, I'm going to show you an interesting finding. This is the optic nerve, carotid, and you will see the third nerve in a minute. So this is cutting the dura along the fourth nerve. And even with the tumor there, the dura is still preserved in a way. But notice here, what's interesting is this is the third nerve, and this is the third nerve. So the third nerve is really coming this way, here. But it was easy for me to see it because the third nerve normal is here and the normal is here. And then the distortion from the tumor is easy to recognize. So by the time we finish, it's the same process. You can see the view like the first case. And this is the view that you get. And the next thing is to remove this petroclival dura and find the sixth nerve. And finding the sixth nerve can be tricky, but and I'll show you in a second how to overcome it in a way. So this is post-op. You can see the anatomy very nicely clean, the tumor. And this is one of those patients who has a...
No, not at all.
This is post-op immediately.
No double vision.
And the sixth nerve was tricky because it's very tight. It usually comes under V1 and splits away at the junction of the rootlets with the nerves around the Gasserian ganglion. That's when it leaves the V1 and dips down towards the Dorello's canal and goes behind the petroclival ligament, which you see here. So the clues to find it is you find V1, you know where the Gasserian ganglion. At that point, you know that the nerve is going to be going in this direction. Then you go back and find the petroclival ligament. Then you know it's anterior to it. So everything posterior is safe, everything more medial is safe, and everything more lateral under Meckel's cave region is safe. And the problem is sometimes the sixth nerve is pushed more posteriorly along the V1 and it drops down if the tumor fills that space between it and the carotid. So in these cases, it makes it more tight around this piece of bone, which is really the medial aspect of the petrous apex. And in that case, we found out that if you remove this bone, it's almost like removing the clinoid to free the optic nerve in a way. Then it becomes easier to dissect it more proximally, and then you can go to the brainstem where the tumor is located, where the nerve is located, and you follow it from proximal to distal, and that's really the safest way, and since then it made my life much easier. So this is removal of that bone, and depend on the anatomy of the patient. Sometimes this area can be removed from lateral to the Meckel's cave, and sometimes you have to remove it from more medial. So you can see by removing this bone, you can free the nerve from all the way from proximal to distal, and you can see it coming out from here all the way up. And this was uh, since we've started doing that, one example is a case that I have done. This patient presented with 6-nerve palsy, and we were able to do the same maneuver, and I was wondering how it will behave. And this was really one of the pleasant surprises for me, because, and I'll show you the post-op about 3 months later. This is her post-op after removal of the tumor, and you can see the functions of the nerve fully recovered, the 6th nerve in her case. And this is not only one case. These are the cases, you see them on the follow-up. And that this can be used for tumors through that region as well. This is a glioma of the hypothalamus, is an example. This is filling the interpeduncular fossa and draping down to the brainstem. There's we have many examples of cases that we can approach in this region, and I'll speed it up some because in this case we did a full transcavernous approach, and what that means is we mobilize the 4th nerve, we mobilize the 3rd nerve, get them out of the way, open the pectoclival junction, open the Meckel's cave, and the steps are almost identical to a lot of these cases. This is removal of the posterior third of the roof of the orbit, then cutting the meningioorbital band, and then following this plane, which is along V1, and then posteriorly. Now, this is a normal cavernous sinus, but it's been used as an approach for a tumor through the cavernous sinus. And in this is the 3rd nerve, clinoid. 4th nerve is here, 3rd nerve is here. This is the 4th nerve being mobilized. This is some fibrin glue in the cavernous sinus. And then this is the carotid. The 6th nerve is here. This is the posterior loop of the carotid. This is V1, V2, V3. And now we remove the clinoid, decompress the optic nerve. I'll speed it up some. This is opening now the dura and opening the sylvian fissure. The reason is this tumor went high in the interpeduncular fossa, so we need to visualize all the little branches coming from the perforators around this region, the anterior choroidal, posterior communicating perforators, and so on. So this is the 3rd nerve now. We found it outside and inside. This is the anterior choroidal. You can see all this is draped around the tumor. Tumor is hiding behind, medial to all these structures. This is the 4th nerve. You can see it intradural. And then we come back extradural. And now we are dissecting from extradural to intradural. And all this dura is going to be removed in this region. This is the 3rd nerve. Skeletonized all the way to the superior orbital fissure. And again, you can see the tumor is hiding. This is part of the tumor being seen here. This is the 4th nerve and 3rd nerve. Now we mobilize them. You see how draped everything around the tumor. Tumor is medial to this region. Now we will open the Meckel's cave. And this is not something complex when you know the anatomy. What's complex is really what our lack of knowledge and ignorance. Now look at the view now. This is the tumor. Now the tumor became on the surface. I'm using a straight scissors and I'm working under the brain, and now I'm removing tumor. This is fourth nerve, third nerve. Look at all the anatomy which was in my way if I wanted to do this through a perional or even, any other approach. This is the basilar artery here. Now you can see this is some Surgery cell in the tumor resection bed. These are the perforators of the PCOM. This is the pituitary stalk. And all this is done from an angle under the brain. This is the view you get, and that's why I use it for basilar aneurysms. Like in this case, you can see the clips and all the anatomy that can be done here. I will skip this. So I think the cavernous sinus is going to be the next convexity, because the indications to do a tumor in the convexity is because, number one, it's pushing the brain. A lot of times they're asymptomatic, but you think this is in a young person, the tumor is growing, we should do something about it. If you feel as comfortable operating in the cavernous sinus, there's no reason why you cannot do the same, because it's even going to be more morbid if you have more problems when the tumor grows. Again, the most prohibiting factor in a lot of times is the fact that it's considered this is a complex, very morbid, and you're going to hurt the patient, or I've even heard maim the patient. So if you're going to do all this, you shouldn't be doing it. But you shouldn't also be doing a convexity meningioma if you're going to not be careful with the vein and end up with a paralysis of a patient. It's the same approach. Simplicity comes from knowledge and experience, and complexity comes from lack of knowledge and lack of experience. So I'm not going to allude, because of our time, to chordomas, which are much more pleasant to remove in this region. Some of them are tough, but compared to the meningiomas, as well as pituitary adenomas, which are also much easier to remove. But again, understanding the pathology, like you see here, how these tumors grow, where they grow from, and how they distort the anatomy, is the knowledge that will lead you to be able to know exactly how to approach these lesions. Example, pituitary adenomas grow in this area, and that's how they grow. And in other cases, this is a medial tumor, which is a chordoma in this area. Again, you can remove this, for example, endoscopically, but we have not to undermine the fact that chordoma resection has to be radical. You have to remove the bone, whether it's lateral or not. You cannot be limited with your approach. You have to be very able to be as aggressive as possible, because that's the best chance for the patient. In this case, we use similar approach, which is also transcavernous approach. Again, this is surgery all under the brain, like we've seen earlier. And I will show you the results of it. We open the fourth nerve, and the same thing in case of the exposure in the patient. This is fourth nerve, third nerve is here. It's very much like the approach we did earlier. And this is a low lesion, which is in the middle part of the clivus, but it's extending more to one side, in this case the right side. So you have to assume the bone is involved, and you have to be aggressive with removing it. And as we've heard many times from Professor Al-Mafti, that with chordomas, you got your breast shot the first time, and you have to remove it. So the same thing here, we open Meckel's cave and remove this dura and the bone, fourth and third nerve are mobilized, and the approach then will get you down to where this is the Meckel's cave, and all this will be open. And then now we did the exposure. This is the carotid, fifth nerve. And now this is the tumor. And we've already removed the bone involved with the tumor. And now we're looking into the mid-clivus, and you can see the basilar up front. This is the advantage is the safety you get. There are approaches where you will find things later, but you don't want to be surprised with a perforator. You don't want to be surprised with the basilar or injury to it. And you don't want to come from the blind spot and then find the pathology. Yes, that's a sixth nerve. You can see how lateral this tumor is. And then the resection part took about 20 minutes. The exposure took a couple of hours. But then we have removed every bit of involved pathology in this region to where we made sure that this patient has the tumor radically removed. And you see this dura and bone has to be removed. You cannot ignore it because otherwise you'll end up with leaving tumor behind. And the MRI would look good the first week, but then on follow-up, you will fail. And that's the view you get looking at all the anatomic aspects of it. So now we come to aneurysms, and there are aneurysms which still need a good operation. Giant aneurysms, in my experience, the majority can be treated. And giant doesn't mean they have a big neck, but a lot of the large aneurysms, which you end up, with endovascular treatments, sometimes converting them to difficult to treat aneurysms. Very small aneurysms have a high rupture rate with endovascular, middle cerebral aneurysms, aneurysm with mass effect, wide neck to dome aneurysms, young age, hemodynamic stress location like the basilar, and also blister aneurysms, patient factors as well. Sometimes you cannot, kidneys are not good, and so on. So there's multiple aneurysms which unfortunately are being pushed to be treated with endovascular options when they are best treated with a simple operation by the right experienced hands. And we are many times converting a simple situation to a very difficult situation. I don't think that's fair for patients. Now we know, and I'm actually reviewing the literature now, that there is, when it comes to basilar aneurysm, we know that durability is superior with microsurgical clipping. We know that rehemorrhage doesn't occur rarely. In my experience, out of 183 patients, we've had 3 patients only who had their aneurysms regrow. And one of them had an angiopathy. And rebleeds are 0 in our cases. So these factors are important to keep in mind, because when you're comparing with 20%, 30%, still there is 3 to 4% chance of rebleeds, and there is ischemic occurrences with stenting and flow diverters up to 11% with major perforator injuries. And it is assumed that this is good because automatically it is considered that surgery is very bad. And every article I read, my blood pressure, I can tell you, goes high very quickly, because the assumption is immediately that microsurgery taken for granted is the worst thing you can do for a patient. So anything else is good enough. And that's not fair. And you can see these aneurysms are the recipes for failure with endovascular treatment because of how wide the neck is. You can see how we can reconstruct them in a much more superior way and durably treat them. And I'll quote Professor de Oliveira here. You know, he used to say, surgery is superior option when done at a superior level. And this cannot be argued when it comes to aneurysm surgery. If an aneurysm surgery can be done at superior level, it is the superior option in a good number of aneurysms, and we cannot deny patients from that. Otherwise, you will see a lot of catastrophes like this. I told you earlier about malignant tumors. This is a good example. This is a patient of mine, was sent to me to do something about it. It's too late. You can see it's been stented, coiled many times with recurrences, and look at the big ball of coils inside the hypothalamus. This is a frequent occurrence in my cases. Giant, large aneurysm. Again, this patient ended up with a mass of coils and then the major strokes in the brainstem. And I can use many examples that I get referred. Unfortunately, I pile up patient and patient referrals of this sort. And we even see so many articles about how to explain the failure, which is good, but at the same time, none of these articles will ever mention that. How about looking at another option, which is surgery? It's not like we did not publish some of the results of our work as well. But this approach to cavernous sinus, through the cavernous sinus, has provided a big advantage in these cases like this, or like this, or like this. And the reason is the real money is in the neck. If the neck is manageable, then that's the success of an operation. But the problem that we had with basilar aneurysms is the problem of visualization in space and understanding the anatomy around it. These are just many examples that I'm showing. Dysmorphic aneurysms, ruptured cases, another case. So based on this and based on our frustration with failures, and I remember Professor Yazagi, when I talked to him about some of the difficult cases we had, he mentioned to me that yes, he had cases he couldn't clip, and he said, you know, pushed me and to go and do more about it, and that's when I explored what options are available. And I realized that really Vinko Dolink has tried this in 1980s and did the transcavernous approach. He used a little bit more medial route at that time, and I used more lateral and medial combined. So it really combines the subtemporal and the pterional approach, plus also an opening through the cavernous sinus, mobilizing the third nerve to where you have a wide window to that region. So the craniotomy is very much like what you do with the extended pterional approach, more temporal side. And then we have to have a wide temporal exposure in this case. Sometimes I trim the zygoma, and I used to remove the orbital rim, but I realized my window and my approach is coming more from a lateral and more anterior, pretemporal, and almost subtemporal. So with these, I realized that what I need is more exposure that will allow me to look from down up in the cases which are high. So I started mobilizing the zygoma or the muscle more inferiorly. And then this is the craniotomy. You can see it's very widely based in the temporal region. And then the next thing is to go to the pretemporal space and dissect the cavernous sinus lateral wall, mobilize it. And then the window we use is this window, which wasn't accessible before. And then by going more posteriorly, you widen the space in this area. And that's where you can see the third nerve mobilize. And the reason to dissect the third nerve in this way is to really preserve its ability to recover its functions. Because the third nerve, I like to use the example of a guitar string. It's like the guitar string. If it is tight, its injury will occur. Music will occur. Music is injury in the third nerve. So you have to mobilize it so that when you can move it right and left, then it will recover. You will have a partial or complete transient third nerve palsy, but 99% of the times, in my cases, recovers within like 4 to 6 weeks in the overall majority. There's few cases will take few months to recover fully. But this is the interpeduncular fossa, which is tight in this case. But then we start opening it, and then the next thing with this approach, we remove the anterior clinoid. You can remove the posterior clinoid, mobilize the arachnoid in this region. This is the posterior clinoid being removed. And then in some cases where the posterior communicating artery is smaller than P1, if you have to, you can coagulate and cut it, preferably in a closer to the P1, P2 junction. Like in this case, you can see a perforator here. You have to go to a perforator-free zone and make sure that you coagulate very gingerly so you don't injure that artery. And then the view you get is so wide in this region, it becomes like a posterior communicating or an MCA aneurysm. So why am I justified to operate on an MCA aneurysm and not operate on a basilic when I can have the same view even better than in some of them? And in this case, if you look closely, there is a clip here on the P1 on the opposite side, a clip on the P1 on the basilar trunk. And then you have a full view of the anatomy. And there is no reason why you cannot clip this safely and permanently and give the patient a cure. This is a curable problem. We cannot take it and make it a chronic problem. It's inexcusable. And we have to keep this in mind. This is the window you get. I've shown it earlier in some of the cases. The view is really unbelievable. And if you notice, we're operating under the brain. It's all under the brain. This is a ruptured aneurysm. You can see the anatomy of this aneurysm, very wide. This is destined to fail, at least 30% chance within the first year, failing endovascular therapy. So in this case, the approach is the same like you've seen before. We remove the anterior clinoid. And the removal of the anterior clinoid is for a couple of reasons in this case. The anterior clinoid will allow you to mobilize the carotid. In some cases, the carotid is in the way, and at the same time enhances the view to the posterior clinoid. So this is the aneurysm. It's a very large, wide-based aneurysm, and you can see that the anatomy is becoming more and more clear. I can see the opposite P1, ipsilateral P1. There is a perforator here, which I already explored. Obviously, this is edited, but in these cases, we put the temporary clips on and off and explore, soften the aneurysm. It's the process that you take your time and until the end where you finalize the clipping. So Professor Yazagil really, his approach when you see it clearly explains how he considered aneurysm not as clipping, not a step. That's a mistake. You don't do it as a step. It's like doing a tumor. You reconstruct and finalize it before you go home. You make sure that all the perforators are filling and nothing of the aneurysm is left in a way. And this is how you cure an aneurysm. This looks like complex, difficult, and so on. Everything we do can become complex if we don't know enough. And it becomes easy and manageable when we know where the traps and how to avoid them in a way. Again, notice the surgery is all done under the brain. Even difficult cases like this, where it was considered inoperable, this is from Sugita's book, this is an example. And again, this is nothing macho about this. What it is proper knowledge of anatomy, proper knowledge of the anatomy of the pathology, and understanding how to approach these aneurysms and having a plan. And then it becomes possible to treat those aneurysms. And again, this is a very tight posterior fossa, but at the same time, this is the view you get. It gets widened and widened. And then now this is the basilar trunk here. The clip is going at the basilar artery. And this is on a perforator-free zone, so you can have no perforator trapped in the clip. And you have blood flowing from the proximal part to the perforator and from the posterior superior cerebellar to the perforator. This is the opposite P1, and the clip is being applied. And look at how I'm being careful so that my clips are not in my way, because this is a wide base aneurysm. In this case, for example, we can do many steps. This is the perforator. You can see I softened the aneurysm. Now I'm studying it. And then gradually you build up a picture in your mind to what is the safest way to approach it. And with experience, you have more options and more maneuverability to where you can clip those aneurysms. You see now the aneurysm is softer. I'm going around it, and it's getting close. I see the picture of Dr. Borba. Maybe I'm running out of time.
But it's okay. It's okay. Go ahead, please.
Okay, I'm almost finished.
Okay. We have more.
And in this case,
6 minutes.
Okay, we have put a clip that compressed the apex of the aneurysm. Then we put another one and removed the first one. This was allowed to be done because of our approach, the exposure that we got, and we were able to clip it successfully. Another case, this is a very low one. We did a full transcavernous approach, like you've seen in that tumors, the chordomas and the other tumors. We mobilized the fourth nerve, and then by the time we finished removing the petroclavial junction, this is fourth nerve, third nerve, Meckel's cave, and then now you are looking at the aneurysm directly. And then now the clipping becomes the easy part of the surgery. And that's, you can see the view behind the aneurysm, and you have no blind spots. And again, this became very accessible with the right approach. So this is our experience now. It's more about 183. They're mostly complex. We did this approach. And the outcomes of these this is in the ruptured group. Almost, this is 62 and 19 and 2, which is almost 83% of these patients are fully independent and functional within a year period of time. This is a ruptured group, and you can see them up here. And in the unruptured group, it's even better, the results. At discharge, 89%, we're in good shape. At 6 months to 1 year, 95%. And again, we cannot deny this option for patients when it is most curable, especially with basilar aneurysms as an example, because if you look at the literature, they have the highest rates of failures and of complications with endovascular therapy. Yes, we don't need to jump on it and do it in a way where we're not prepared, but we cannot deny it to our patients for their future outcome. So we have 3 that we couldn't clip. One of them was coiled actually, and the other one was previously clipped. It was very scarred and difficult. We have 3 that regrown only. 2 of those were reclipped that regrew. The recovery of the oculomotor palsy is really excellent once you skeletonize the nerve and clean it well. So everything can be complex if we are not prepared. But if we spend time, we learn from our teachers, and you continue to stay a student, improving on what you do, then complex things become simple. And like a lot of things we do, and this is a good example. This is a picture which, anybody would think it's difficult to do, and it may take, it may take me a week or two to do something like this. But this is a guy who mastered his technique, is a good example. And this is what he's doing. This was on TV, and within less than 5 minutes period of time, he was able to finish this piece of art in no time. Why? Because he had a plan, he knows his colors, he knows his brush, he knows the final outcome, how it looks, and he knows the technique of how to get it. And he is even doing it upside down, you will see. So things which are complex are things which we don't know well. And things which we know well become simplified. And that's how we should approach a lot of things in our specialty. Otherwise, we're denying patients good treatments which can last for a long time. So I will stop here. And this is the last slide I will show, where Professor Yazigil puts it beautifully, that we should have the courage to continue doing new things, but in a judicious way and based on professional competence, which is to go and learn it and do it right. Again, thank you for this opportunity, and I hope this was useful to some of you.
Thank you, Dr. Krisht. It was beautiful as usual, and I think the Michelangelo slides are very fortunate, because it's really a work of art when you see you operating and showing us the